Don't worry, Jenny, I'm very short. And despite what 2-inch heels, I'm still barely covering this. So it's a pleasure to be here today. And I just want to say I'm thrilled to see the turnout. And I really hope that this spurs in our city and in our community a wonderful grassroots network for you to travel with through your fertility journey. So we're not done here yet. You have to continue to support each other. So I'm going to talk today about how your lifestyle affects your fertility. We're going to go through 6 different domains of lifestyle issues and discuss how they affect your fertility and what you can do to change them. Now, I do have to warn you that each physician, each clinic has their own rules, their own guidelines when it comes down to this. So yes, I can provide you with what's out there in terms of the scientific evidence so far, but that doesn't negate the importance of your physician and your clinic and their recommendations. So when I started to really start to delve into the evidence behind this topic, there wasn't a lot out there, interestingly enough. You would think with such a large population of people having to deal with this particular problem that I would, have to go through tons and tons of literature, but there wasn't a lot. So I also think it's important to understand that when we start to talk about the evidence behind these things, we really not only need to look at what the study is, but we also need to look at the outcome that is measured. There's a difference in the outcome of ovulation in women who don't ovulate versus the outcome of a live pregnancy. There's also a difference between a parameter on a sperm or a semen analysis versus actual a live birth rate. So it's important to look a little bit more in detail at some of these evidence, and we're going to go through these in detail. And lastly, understand that not everything on the internet has been studied. Please. Not only has it not been studied, most of the time the particular studies that are done on things that you see on the internet are studies that were not designed properly. Meaning they weren't done randomized fashion. They weren't done, what we consider as scientists in a gold standard type of fashion. So yeah, it doesn't mean that they're wrong. It just means that I can't, as a scientist, recommend it because it hasn't been studied quite as well yet. So let's talk about weight first. And we're not just talking about weight anymore, right? We're talking about your BMI. Isn't that one of those 6 things that Dr. Oz tells us to talk about is know your cholesterol, know your BMI. Now, what your BMI is a weight in kilograms divided by your height in meters squared. You think, well, gosh, how do I do this? Just go online. You can calculate it out these days. There's wonderful charts out there. There are classifications for weight on that particular number. If your BMI is between 18 and 25, you are considered of normal weight. If your BMI is above 25 and between 25 and 30, you're in the overweight category. And if your BMI is greater than 30, you're considered obese. Now, to put this a little bit more in perspective, let's take a 5'5" woman. If she weighs 120 pounds, her BMI is 20 within that normal category. If she weighs 150 pounds, her BMI is 25. So now she's starting to teeter on that normal weight to overweight category. And when she reaches 180 pounds, she's now starting to be classified in the obese category. So why know your BMI, right? Well, Dr. Oz will tell you it's because it predicts long-term health outcomes. Things like diabetes, heart disease are related to your BMI. Secondly, the studies that have been done to look at how weight influences ovulation and fertility have all been done using a woman's BMI. So it's important to know. Lastly, BMI is not the perfect answer, of course. I have wonderful athletes who are collegiate gymnasts, and they are falling into the overweight towards the obese category because they have huge muscle mass. And they're very healthy women. So body fat's also going to play into this. But right now, this is the best that we have to help guide you and us. So what happens if your BMI is too low? Well, in women with a BMI less than 17 to 19, it is associated with a loss of menstrual cycle, a loss of your period, and a loss of ovulation. And it's due to an overall caloric deficiency or calorie deficiency. That can be due to one of 2 things. first, over-exercise, and 2, low-calorie intake. So how do you correct it? Well, you have to correct that deficiency, either by decreasing the exercise or increasing the caloric intake. In a nice study, well-designed study out there, in women with low BMIs who spent 6 months correcting their caloric intake, most of them gained a little bit of weight. In those women who did not have periods, over that next year, many of them began to have periods, and after they followed them for a year, 73% of them became pregnant. So to correct your low BMI, correct your energy intake. What about an elevated BMI? There have been multiple studies out there looking at the effects of an elevated BMI in both men and women. So women with an elevated BMI, there's an association with problems with ovulation, higher insulin and testosterone levels, which associate themselves with polycystic ovarian syndrome, increased miscarriage rates, and decreased success rates when you get into those advanced reproductive technologies such as IVF. Now, men, you're not alone. You don't get away here too fast. Your elevated BMI also affects your fertility. Elevated BMI greater than 30 is associated with low testosterone counts, low sperm counts, and abnormal semen analyses in terms of motility, remember that's the swimming sperm, and morphology, and that's the actual shapes of the sperm heads and tails. So this affects both women and men. Now the first line treatment, of course, I wish there was a magic pill out there. There's not. The first line treatment is good old-fashioned diet and exercise. We typically recommend visiting a dietary consultant, such as a registered dietitian, or investing in some type of group treatment, such as Weight Watchers. Studies show that people who do either one of these 2 interventions have greater success and greater satisfaction at the end of their journey. The important thing to do is focus on your diet first, and that includes decreasing your caloric or your calorie intake. It also includes moving more, and that means lifestyle changes such as increasing your exercise or increasing, your movement is what I typically call it. It doesn't mean I want you running a marathon. It means I want you out walking a couple times a week. There's no particular drug therapy that is recommended while you're trying to obtain pregnancy. And this wonderful fad HCG diet, please do not start while you're trying to become pregnant. The couple of patients I've had on this or who went and did this without my knowledge actually have miscarried. So there's little data out there about how this affects long term, but please do not attempt the HCG diet. In women or men with an elevated BMI of greater than 40 and have had difficult losing weight their entire lives, things like lap band surgery or gastric bypass can be options for you. So after you lose weight, do you really improve your outcome? What does the science show us? Well, the science shows us 2 things for women. One is an increased frequency of normal ovulation. And remember, that's growing up an egg and ovulating that egg. And 2, decreased miscarriage rate. There's a wonderful study out there that looks at ovulation. It took all these women that failed Clomid, who had an elevated BMI, and they gave Group A 6 weeks of diet and exercise, and they lost weight, and Group B did nothing for 6 weeks. And then they all gave them Clomid again. In that Group A that had some weight loss, they were associated with a 38% ovulation rate versus Group B that only had a 9% ovulation rate when they gave them Clomid again. We know that weight loss also decreases miscarriage rate in a group of women that were studied that had a high percentage of miscarriage and a high BMI. When they treated them over 6 months with diet and exercise, their miscarriage rate after that period of intervention dropped from 75% before the intervention to 18% afterwards. Now, as far as men goes, we don't have a lot of data or research out there right now that helps guide us in terms of what to recommend. The only study out there right now that really looks at this fact talks about the fact that men who undergo gastric bypass have improvements in their testosterone levels. And remember, testosterone, as Dr. Rakes taught, drives sperm production, and so that would improve your sperm production. So the optimum weight is somewhere between this BMI magical number of 18.5 to 25. This particular optimum weight range is associated with little or no increased risk of both long-term health issues and fertility issues. And I think it's really important to start to incorporate healthy lifestyle choices into your life while you're undergoing your fertility journey. So what about this fertility diet that's out there, right? The fertility diet was published by Shavaro back in 2008, and he actually has a book out there. And he was the lead study author on the Nurses' Health Study that looked at 18,000 women nurses over about 8 years and studied a bunch of different things with these nurses. Their diet, their lifestyle, pregnancy, their heart rate, their blood pressure, their cholesterol. And when he pulled out the stuff about fertility, he found that certain dietary factors were positively associated to women who ovulated. So that means certain dietary factors make you more likely to have normal ovulation. And those dietary factors were low animal protein, low glycemic foods, and whole milk products such as yogurts and cheeses. Now, that's the only study out there that really looks at this in a good way. And it's only linked to ovulation. So there's no one fertility diet that boosts your ability to become pregnant. Does that mean I don't endorse you eating your fruits and veggies? No. It's good for your overall lifestyle, but do I think it's going to necessarily improve your fertility 100%? No, not right now with the data that's out there. So our recommendations are to visit a registered dietitian if you're starting to get involved in this to really help answer your questions. The second most thing I get asked about weight and diet and stuff is supplements. What's the magic supplement out there that I can take to really increase my fertility? Now, up until a few months ago with guys, we were telling you not much we can do for you in terms of those things. But there was a large analysis that came out of multiple studies that showed that men with sperm issues, if they started to increase their antioxidant use, they had a higher rate of pregnancy in their partner. So people are taking this, and physicians are taking this as, yeah, start your guys on a multivitamin with an antioxidant. Do we know which antioxidant yet? No. Do we know if it's A, B, C, D, all of those ones? No, not yet. So more studies need to come out and evolve to help us answer this question. For women, the most important supplement out there is folic acid while you're trying to conceive. And the importance of folic acid is it prevents the neural tube defects, which are spinal cord disorders in babies. And so if I were going to recommend one supplement out there for women, it's just your folic acid that you're typically taking in a prenatal vitamin. Tobacco use, the next of the 6 domains. Now we know tobacco use is decreasing among our United States population. But we understand that tobacco contains several hundred substances. Those include things like nicotine, carbon monoxide, and other things that can mutate your DNA. So there is strong evidence. There are good studies out there that link tobacco to poor outcomes in terms of all facets of fertility, from egg development and ovulation to transport down the fallopian tubes in terms of the eggs and the embryos, poor issues with fertilization and early embryo development. What's interesting is not only when a woman smokes does she affect her own fertility, she actually also affects the fertility of her baby. There are studies out there with decreased sperm issues in little boys whose moms have smoked. So it's really important for women to curb this. In women who are trying to naturally conceive, meaning they're undergoing nothing else but they're trying on their own, we know the chance of them becoming pregnant decreases as the number of cigarettes they smoke per day increases. We also know that smoking increases the rate of tubal disease and endometriosis, and increases the rate of what's called diminished egg number or diminished ovarian reserve, and can increase the chances of premature menopause. When we look at women who are undergoing IVF, we know that smokers have a decreased egg number, decreased fertility and pregnancy rates, and increased miscarriage rates. So for females, smoking affects multiple facets of your fertility. What about guys? Not as many studies out there for the guys. We know that when we take tobacco and we put it in a little culture dish with sperm, it can induce DNA damage in that sperm. But as far as looking at large populations of men who smoke and their fertility, there may be some small association with minor reductions in sperm counts or morphology, but no fertility or pregnancy issues later on. Now, I caveat this with, in vitro fertilization, there are studies out there that help guide us with this. Smoking in men is a predictor of outcomes with fertilization with that ICSI that we talked about before, the intracytoplasmic sperm injection, where you're taking that one sperm and injecting it into the egg. If you smoke, you are at a higher risk of having abnormal fertilization. It also is a predictor of lower pregnancy rates. So, even though the data out there isn't great, we do recommend, of course, that men stop smoking during their journey. So tobacco it's generally accepted among most physicians out there that tobacco cessation, smoking cessation should be an integral part of your treatment for both men and women. And what about caffeine? We love our coffee latte from Starbucks and our Diet Coke in the afternoon to get us through. What's really the evidence out there behind how it affects your fertility? In the United States, 89% of us consume caffeine in the ages range of 18 to 34 years old. The average intake is 134 milligrams a day. We know that pregnant women on their own decrease their caffeine intake to an average amount of about 125 milligrams a day, but 15% of all pregnant women drink more than 200 milligrams a day. So how much is in the stuff that you drink? In your brewed coffees, it's about 130 milligrams of caffeine in a 6-ounce portion. Your Diet Coke runs you about 46. However, look at your Starbucks tall coffee, 375. So I want to point out that things like coffee and sodas not only have caffeine, but you also have to remember that things like chocolate have caffeine in them as well. We know that caffeine is absorbed in the stomach. It's detected in your tissues about 30 minutes afterwards, and its concentration peaks at about 2 hours after you ingest it. And you're metabolizing this particular caffeine, and that particular metabolism rate depends on multiple things, including genetics and your environment. Things like smoking actually accelerates your caffeine use, and then it's excreted by the kidneys. So what about caffeine and fertility? There's little evidence out there that caffeine has a detrimental effect on fertility. The initial studies back in the 80s and 90s that were designed are very flawed. They're not what we consider good gold standard studies that we can implement based on their findings. They did show small effects on pregnancy chances at 200, 300, and 500 milligrams a day. The largest study is back to that nurses' health study that we talked about before that followed those 18,000 nurses out for 8 years and looked at diet and caffeine consumption and how it related to ovulation rates. Remember, not fertility rates necessarily or pregnancy chances, ovulation rates. They found that overall intake of caffeine was unrelated to an ovulation disorder. However, when they started to tease out the data, one interesting thing that they found was that the intake of soft drinks, and it didn't matter if it was a Diet Coke or a regular Coke, was positively related to ovulation issues. So this is an interesting, conclusion. And the authors really pointed out that this particular study wasn't designed to detect these small little things, and it was just a really interesting observation that they found and published. So I think there needs to be more studies about this before we really know what's behind the science with this issue. So we don't know really in terms of caffeine and fertility what the recommendations are, but there does not appear to be an association between caffeine consumption less than 200 to 300 milligrams a day and increased risks of fertility issues. So it may be prudent to limit your caffeine to less than 200 milligrams a day. Now for men, there is actually really no great study out there. The only one that I could find was published back in 2008, and it looked at a Danish population, and it took women who used caffeine and had sons and looked at the sperm parameter of the sons later on in life, and there was no effect on the sperm parameters of the sons in the women who had caffeine use. And interestingly enough, in those sons, if they used caffeine, they didn't have an increased risk of sperm issues as well. So, what about caffeine during pregnancy? We've talked about whether caffeine can affect ovulation or fertility, but what about while you're pregnant? We know that caffeine can cross the placenta, and the fetus actually has to metabolize caffeine, and it does so at a very slow rate. There are no adverse fetal outcomes in terms of developmental disorders, genetic disorders related to caffeine use in women and their offspring. There was one study that looked that when women did drink caffeine, there was increased heart rate in their fetuses that was short-lived and not long-term. However, there is some really good studies out there linking elevated caffeine use and the increased risk of spontaneous abortion, also known as miscarriage. In most studies, there seems to be a relationship between the amount of caffeine women take and their rate of miscarriage in a dose-response relationship. And what that means is the more caffeine you drink, the higher the rate of the miscarriage. But it is unclear what the safe threshold is. And so most medical societies, the people who govern who we are and do our board testing and all of those wonderful things that we have to go through, recommend that women, while they're trying to become pregnant and while they're pregnant, limit it to less than 200 milligrams a day. So right now we're saying, for the most part, limit it to less than 200 milligrams a day, and that it could be linked to elevated risks of miscarriage and female subfertility, and that there's no association between caffeine and sperm parameters. So once again, you can find most of these numbers online through your Google search, and they're very easy to come by, and I think Starbucks actually is publishing them right now online and has them in their stores. Starbucks isn't going to like me much. What about alcohol? We all want to know that we can have our glass of wine with our girls or a beer with our guys when we're going through this process, right? It helps us relax. It helps us decrease our stress. Now we're going to start off with guys. We know that heavy alcohol use in guys, and what that is defined as is greater than 14 drinks per week, is associated with reduced testosterone production. It's also associated with impotence, and it's associated with decreased sperm concentration, motility, and abnormal morphology. Moderate alcohol use, and that's defined as 3 to 13 drinks per week, does not appear to be associated with decreased fertility. So guys, go have a beer, just don't have too many. What about women? It's a little harder for us. The studies out there are really mixed. We know that in terms of fertility, that high rate of alcohol consumption, defined as 14 drinks or greater per week, is associated with a longer time to achieve pregnancy and a higher risk of undergoing an infertility evaluation. Studies on moderate alcohol consumption, and that's that 3 to 13 drink per week, shows that there's no association with infertility or ovulation issues. What about alcohol and IVF? There's actually only one study out there that looked at this particular issue. In women undergoing IVF who had moderate alcohol use, they had a decreased egg number of eggs that were retrieved, increased risk of not achieving a pregnancy, and increased miscarriage risk. In males, it increased the risk of not achieving a live birth. So decreasing the alcohol intake while you're undergoing IVF, I think, is important right now with the data that we have out there. So high use, greater than 14 drinks a week, in men is associated with low testosterone and abnormal sperm issues and poor IVF outcomes. In women, is associated with poor IVF outcomes and birth defects, which we're going to talk about in a second. Moderate alcohol use in men is not associated with infertility in men or women. Now, I have to caveat this with, there is no safe amount of alcohol while you're pregnant. We know that there are significant birth defects and syndromes related to alcohol use during pregnancy. So the current recommendations for women are no alcohol attempts during conception or during pregnancy. What about drug use? I kind of played about whether or not I should include this topic, but once I really started researching the numbers on this, I thought it was applicable. I'm going to talk about marijuana use and how it affects fertility. Marijuana, or cannabis, is cultivated in every country. It can be smoked or eaten. In the United States, the most common use is smoking. Interestingly enough, the overall lifetime prevalence, or the chance of somebody smoking in their lifetime, is approximately 42% in the United States. We actually have the highest rate in the world. You would think the Netherlands, but it's us. So there's no good studies out there looking at marijuana use in sperm. There are 2 studies out there, one that shows abnormal hormone profiles in men who smoke cannabis. There's also another study that I found quite interesting where they took sperm in a culture dish and they added a little bit of the marijuana in it. And of course they slowed down, they stopped swimming. So decreased sperm motility is associated with cannabis use. There's no great studies out there to help us guide us. I know, the pictures in my head just kept going around when I was reading that study. Marijuana use and female issues, there's really no good evidence out there or data out there. There is one study back in 1990 that showed that women who smoked marijuana at any point during their lifetime had an elevated risk of infertility due to ovulation issues, and it was highest if it was used within 1 year of trying to become pregnant. Now, there is one study out there that accurately looks at marijuana use and IVF outcomes and showed that both in men and women who smoked marijuana, not only in that prior year prior to IVF, but an accumulation of lifetime heavy marijuana use. And both of those things were associated with poor outcomes with IVF in terms of eggs achieved, smaller birth weight infants, and IVF successes. So I'm kind of running through because we're getting close here. So for men, there are those nice culture studies that show that they get a little slower. And there's studies that show decreased abnormal hormone levels in men with marijuana use, and there's association between poor IVF outcomes and heavy use. And for women, there is that one study that showed ovulation issues in women who smoked marijuana and poor IVF outcomes. And now we're going to get to the last one, and it's exercise. Right? Don't they all tell you to stop exercising or increase your exercise? And it's a real hard issue to get at because there's not a ton of data out there to help us with this. This tends to be more of a clinic decision or a provider decision. We do know that on the extreme, women who heavily exercise, so these are talking my ultra marathoners that are out there running their 50 miles, or my elite gymnasts that start to lose their periods and have no ovulation left, we know that it changes their hormones, it changes their progesterone and their FSH and their LH, and it lowers their body fat. So we know that extreme definitely changes fertility, and that's associated with greater than 7 hours per week, okay, in the studies. But what happens about your just normal exercise, and what happens when you're going through IVF? Recommendations, like I said, are really based not on evidence, more of a scientific, more on an individual clinic basis. There is a known risk of women who are undergoing IVF when we're growing your eggs up and making your ovaries a little more swollen and a little more tender, that there is a risk of ovarian torsion. And what that means is as your ovary gets big and swollen, it can twist off on its blood supply. When it does that, it's a surgical emergency and you risk losing that ovary. And so the thought process is while we're making your ovary nice and swollen, that you shouldn't be doing jarring exercise. There is only one study that looked at the hours of exercise and the effect on their IVF outcome. And they showed that greater than 4 hours a week was associated with a decreased IVF pregnancy rate, but it did not distinguish a type of exercise during that IVF treatment. So most clinics out there will say, yeah, things like walking, non-jarring activities are okay during IVF. But for women who are undergoing other types of fertility treatments like oral medications, exercise is important, I think, and it's an important overall lifestyle change because it helps influence your weight and your BMI, like we talked about before. So no great data out there, unfortunately. There's no clear consensus. During IVF, exercise is usually limited, and I do note that it's a wonderful coping mechanism for certain women during fertility treatments and workups. So we talked about those 6 domains and actually the evidence behind, but once again, each clinic has its own guidelines and its own recommendations, so ask your physician. So thank you, and I'm actually going to go through the couple of questions that I got preemptively prior to this. And the first question actually dealt with stress and infertility and how your job or your lifestyle stress affected your fertility. And I'm really going to echo with what Carrie said, that we don't have tons of data out there to say that stress affects tons of your fertility outcomes. But I think it's really important to stress that stress is that having coping mechanisms there for you during your fertility treatments is even more important. Do I think you need to go change your job? No. Do I think you need to get counseling to help your marriage through this process? Absolutely. Those things are helpful. The second question I got out there in terms of lifestyle issues was acupuncture and whether or not the data was out there in terms of acupuncture and helping. Now, this is a pretty controversial topic. There are some studies out there that are very well designed that show no changes in pregnancy rates with acupuncture with IVF. There are some older studies out there that aren't as well designed, but they do show increased pregnancy rates with IVF and acupuncture. So we're kind of, as clinicians, caught in the middle of these two things. So my thought process is if it helps you cope, if it helps you calm during your process, if it makes you feel more centered, go for it. It does not hurt. It can only help. So yes, those kinds of alternative medicine things, they can help. The last one I got was about herbs and reproduction. And I think you have to really caution yourself on some of the herbs out there. I did have a patient back in Salt Lake City that was taking black cohosh while she was undergoing her fertility treatment. And funny, she ended up in the ICU with liver failure. So you have to be very careful about learning about these herbs. It doesn't mean that there aren't great ones out there. You just have to really look into it. And there's not a lot of scientific data out there helping us with this as clinicians to guide you. Okay? And I think I'm up on time. And I think we're done.
We have 2 minutes for...
Oh, we have 2 minutes. 10. Oh my gosh.
On the soda discussion,
yes.
You need a little bubble at the end of the day, and you go for non-caffeinated. What are the issues surrounding the other additives in soda? Period. Aspartame.
Yeah, that's a really good question. I think that was alluding, so her question was about whether those other additives in soda, such as aspartame, change fertility. We don't have a study addressing that particular issue. The only answer that we have to that right now as scientists and clinicians is that one study that looked at those 18,000 women and followed them over those 8 years and looked at, whether or not soda, or actually whether or not what type of dietary factors affected ovulation. Now, when I talked about this, a sub-study came out of that showing that there's an increased risk of ovulation issues with soda, and it didn't matter whether it was diet or non-diet. And I think that's important. I don't know what it means quite yet, to be honest with you. I don't know which additive to avoid. I don't think anyone does, really. We can guess, but there's not a lot of scientific data out there yet. Yes, sir?
Do you have any insight or thoughts on why there are more studies on herbs?
Do I have any insights or thoughts about why there aren't more studies on herbs? Yeah, I have a thought. I think that many of the companies that provide the herbal supplements and many of the producers of herbal supplements don't have the resources to study them in a proper scientific way. So to really study something, you have to do what's called a randomized controlled trial these days. And you'll hear this out there in the science and the media. And what that means is you take 100 women and you split them in half randomly. So every time they come in, they go into one of 2 piles. And then those particular women are randomized to either get the herb or a placebo. And then you follow the outcomes later on. To do those types of studies, it takes a lot of money and a lot of time, and a lot of these small companies don't have that resource. Did I get off that easy? Well, thank you. Oh, yeah.
What about eating organics? I've heard of some fertility clinics suggesting that, others saying it doesn't matter.
Do I think you should eat organics? Is the question. Does it affect fertility? What are the current stuff out there? I don't think we have a great scientific way to answer that question, meaning there's not been studies out there where they've taken women and given them organics versus not organics and followed their fertility later on. That being said, Do some of the pesticides used, are they starting to show that these environmental toxins that we're exposed to can change things? Yeah, it's a really hot new research field out there right now, looking about how environmental toxins can do things like change sperm parameters. There was one study published that looked at air pollution, and people who lived in high air pollution areas had decreased sperm counts. So yeah, can environmental toxins affect things? Yeah. Do I know if it's not, which one it is? I mean, you know, which organic food you should buy? No, not yet. Okay, thank you.